Appropriate management of postpartum hemorrhage requires prompt diagnosis and treatment. However, there's some debate on various PPH prevention and management strategies and the corresponding scientific evidence. What do you believe is the right treatment strategy to prevent and manage PPH? Listen to find out more. In this third episode of a 4-part podcast series on severe PPH, we discuss various topics on the management of severe PPH, and we also explore the scientific evidence combined with the clinical experience of the experts. This podcast is an initiative of Core2Ed and supported by an independent educational grant from Novo Nordisk. We're very excited to listen to your discussion.
So I'm delighted to introduce you to today's speakers, Professor Loïc Sentilhes, who specializes in the prevention and treatment of postpartum hemorrhage at the University Hospital, Bordeaux, France. Professor Christian von Heymann, who has a special interest in obstetric anesthesia and the management of patients with postpartum hemorrhage at the Vivantes Clinic in Friedrichshain, Germany, and myself, Dr. Homa Ahmadzia. I'm a maternal fetal medicine specialist at the Department of Obstetrics and Gynecology at Inova Health Systems, United States. Postpartum hemorrhage, as we all know, is the leading cause of maternal mortality worldwide. It's an incredibly important topic, and early recognition and diagnosis is paramount. At many facilities, we might have algorithms to predict postpartum hemorrhage and who is at risk, but oftentimes these don't work, and we miss patients who might have severe postpartum hemorrhage. In this podcast, we're going to talk about several topics that are important for the prevention and management of postpartum hemorrhage. We're hope to attempt to review the latest evidence and gaps in scientific literature for the clinicians, the patients, and the health systems. So I will facilitate discussion as moderator, and now I'd like to welcome the experts. Professor Sentilhes, if you could help introduce yourself, please.
Yeah, hello everybody, I'm Loïc Sentilhes. And so in this podcast, we will discuss new strategies for prevention of postpartum hemorrhage that has emerged this last decade, but the level of evidence for these new strategies remains mostly low. And we hope that this debate will help the listeners to determine the place of these strategies in the algorithm of the PPH management.
Professor von Heymann.
Thank you, Homa, for the nice introduction. I am by training an anesthesiologist, intensive care physician, and I have a special interest and did some certification in thrombosis and hemostasis issues as well. And to me, as you can see from the composition of the panel, PPH is a challenge to a multidisciplinary team consisting of the obstetrician, that is clear, of the anesthesiologists who comes to the situation in most instances. And therefore, I'm very much looking forward to have a lively discussion with you on the most debated issues in the treatment and management of severe postpartum hemorrhage.
Well, thank you both for joining us today. So let's jump into our first topic. Should tranexamic acid be used prophylactically to prevent postpartum hemorrhage? As you may know already, tranexamic acid is an antifibrinolytic, which helps to stabilize fibrin and reduce bleeding or blood loss. It's been consistently shown in non-obstetric trials to improve outcomes and reduce bleeding by about 30%, and with the most recent PROS-3 trial in non-cardiac surgery. In the past 3 to 5 years, it's been studied in many randomized trials, such as the TRAP2 and MFMU multi-center study, with some equivocal findings on efficacy for the prevention of postpartum hemorrhage at delivery. Professor Sentilhes, can you discuss some of these studies a little bit more in detail?
Yeah, thank you very much, Homa. As everybody knows, in the women trials, TXA was shown to reduce bleeding-related mortality among women with PPH, especially when the drug was given shortly after delivery. And this result suggests that it may prevent coagulopathy after delivery rather than treat it. And in the TRAP trials, among women with vaginal delivery, TXA decreased significantly the rates of blood loss above 500 millimeters, PPH according clinicians, and the use of uterotonics due to bleedings. In TRAP2 and MFMU trials conducted among women undergoing cesarean, the mean peripartum change in hemoglobin that was a secondary outcome was lower in the tranexamic acid group, although the clinical relevance of this result is questionable. And finally, cost-effective analysis suggests that TXA for the prevention of blood loss might be cost-effective, although the effect size in cost and effectiveness is low.
Yeah, thank you for those comments. And Professor von Heymann, can you tell us and share a little bit more about your perspective about the prophylactic use of TXA?
Yeah, thank you, Homa. I'm full of respect for the work Professor Sentilhes did with conducting the TRAP and the TRAP2 trial. And we carefully analyzed these trials when we updated the German guideline on diagnostics and treatment of PPH. And we finally came to the conclusion that most likely the prevention of blood loss after vaginal delivery and cesarean section is not the best indication for tranexamic acid. And accordingly, our experience is that most of the patients are happy and the blood loss is confined to a reasonable volume with the use of oxytocin and carbetocin. That means uterotonic agents alone. And for these patients, we feel that the prophylactic use of tranexamic acid is not justified. And therefore, we recommend, and that was written down by the guideline group, that the use of tranexamic acid in those patients who have an increased blood loss, or patients who have a greater blood loss of 500 mils as measured in a calibrated drape, or in whom the obstetrician has the feeling that this patient is having a diffuse coagulopathy or diffuse bleeding tendency, that these patients, and I'm convinced that these patients are the best population for the administration of tranexamic acid. And that means early, that is in most instances in parallel with uterotonic treatment, either oxytocin or the next step, cyprostone, the prostaglandin derivate.
Yeah, thank you for sharing that. I'm curious to hear if both of you have opinions here, where these large randomized trials that were conducted gave TXA at umbilical cord clamp. And that's mostly to avoid these theoretical risks for the neonate as it potentially crosses the placenta. Do you think that we still need additional trials that are given TXA pre-cord clamp to address this question? Because bleeding clearly starts, before the start of surgery, or right at the start of surgery, rather, and not at umbilical cord clamp.
Yes, it's an interesting question because, some people, considering that the small effect that was observed in the TRAP trials and in the MFMU trials, that was because the TXA was given too late after the beginning of the delivery. And some other trials, small singers with methodological limitations have shown higher effects when TXA was given before the incisions for the cesarean and before the cord clamping. But yes, I think it will be interesting to have additional evidence about the effects with between the delay of the administration of the drugs and the plain delivery. But in France, I think it will be difficult to make such a trial because we will have not the authorizations to give TXA before the cord clamping because we have no data that considered that the safety data, that no higher risk of, in particular, ischemic vascular events in the neonates. And we know that blood coagulation of the neonate is very different than the coagulations of the adult. So in France, it was impossible to perform such trials, but I will be interesting about other trials that could be performed in other settings.
Yeah, that is an interesting perspective. I think the take home what I've heard so far is, that TXA does clearly reduce blood loss and hemorrhage morbidity in non-obstetric large randomized trials. In obstetrics, this data has been somewhat inconsistent. It may be due to the fact that participants who are, quote, higher risk, haven't always been studied in large numbers, or perhaps given the timing of the administration prior to delivery hasn't been done. And so I think we should stay tuned for some of these trials I know the TRAP-PREVIA trial, it sounds like, hopefully will be coming out in higher risk populations. And the IM Women trial, I've heard as well, will be giving TXA precord clamp in 30,000 patients. So I think we'll have some more data to answer these questions. So maybe let's shift gears now to talk about the next topic, initiating blood transfusion or blood products. Should those be as soon as possible or based on certain criteria? In obstetrics, as we know, the timing of transfusion is not always clear. Sometimes hemorrhage can be quote unquote controlled, where the bleeding is gradual and accumulates to higher volumes over the course of the surgery, or sometimes rapid and uncontrolled and unexpected. The term uterus has about 500 milliliters of blood per minute that circulate. And so when you have an extension into the uterine arteries or large venous sinuses, it can be very brisk and accumulate very fast, even within a minute or two. The decision about transfusion can be by the obstetrician at times, based on the amount of blood loss in the field, or the anesthesiologist, especially if the patient is hemodynamically unstable. And so, sometimes lab values are used to guide this, but I wanted to hear a little perspective first, before we jump into that, about the evidence about timing of administration. If Professor von Heymann, when do you think is the optimal time to consider a transfusion for obstetric patients?
Well, if you mean by transfusion, red blood cell transfusion, we learn from a lot of prospective randomized trials in other fields of medicine, especially in the fields of cardiac surgery, intensive care medicine, and other specialties, that most patient populations do not do worse when they are transfused restrictively. Having this said, you will ask what is restrictive, and that what was usually adopted as a threshold was a hemoglobin value between 6 and 7 for these patient populations. And coming back to the population of young healthy mothers, then in these patients, and I assume that most of them are healthy from a cardiovascular and pulmonary point of view, we would adopt a transfusion threshold of below 7 to be safe in these mothers and also in the children. And we recommend, and this is a German and a European guideline, to transfuse the patients when the hemoglobin drops below 7 and is still hemodynamically unstable. Then he will definitely, or she will definitely need a blood transfusion. But and that is our experience, and if the patient stabilizes very quickly, then we can even tolerate a profound anemia below a hemoglobin of 6 in these patients. Those patients will then probably require some iron replenishment, because then due to the blood loss, they come into sort of an iron deficiency anemia and need some iron to stimulate the bone marrow to produce red blood cells.
Thank you for sharing that. Professor Sentilles, can you comment on your experience in timing of transfusion and thresholds?
Yes, it's a big issue on the management of PPH, because we have no real high-level data on obstetric context. And I think that PPH is quite different than in other contexts for bleeding. So I share the concerns regarding the morbidity associated to the transfusion of blood loss, and to try to avoid blood loss. It's an important key issue of the maternal outcome, as it was underlined by Christians. And I agree that the timing of transfusion during PPH is not evidence-based. However, we have some limitations, of the bedside of standard laboratory-based hemoglobin, is that the level of hemoglobin remains often normal at the initial stage of the PPH, even when massive blood loss occurred. So when we have a policy of transfusion based on hemoglobin level, sometimes it's too late, because when we control 2 hours after the blood loss, we can see important drops of the hemoglobins that was not expected. So I have to say that we have to be concerned about that at the initial stage. Even with massive blood loss, the level of hemoglobin can be normal. So that's why I believe that blood transfusion has to be decided mainly on clinical signs, in particular with the assessment of the quantitative blood loss, even if there is some issue about the quantitative blood loss. But when we use collected drops, usually we have an about a good assessment of blood loss. And with hemodynamics effects too, and the flow of the blood loss, it's important for me. And in my opinion, it might be too late to consider a blood transfusion for an ongoing PPH, not when the PPH is over, but ongoing PPH, when the hemoglobin has dropped below 6 grams. And the French guidelines, I recognize that it's with low level of evidence, but the French guidelines suggests that the administration of units of pyruvate blood cells should be based mainly on clinical signs of PPH severity without necessarily awaiting blood test results, and that the objective of transfusion is to maintain an hemoglobin concentration above 8 grams.
Concerning the point Loïc made with using the hemoglobin thresholds for transfusion, and I completely agree that clinical symptoms are as important as the hemoglobin value to guide the transfusion of packed red blood cells, especially if in the light of that not all hospitals have an easy access to hemoglobin measurements. So sometimes you only have to depend on clinical symptoms to guide your transfusion decision. But I would also like to say that every patient who has a bleeding problem needs some careful observation and treatment in a specialized unit. And we usually admit those patients to the intermediate care unit, where we have a close monitoring not only on the cardiovascular system but also on the blood gases, and so that we can quickly decide whether the patient needs some more treatment or not. And I think this is an important point.
I can see there's some differences of opinion in the timing of the transfusion. I think some of that comes from the limited data that we have in terms of thresholds, and specifically the obstetric patient population. A lot of, I know the guidelines we extrapolate from cardiac and other fields, and we really could use some more guidelines based on trials in this field. I think that's a deficiency or a gap that we're highlighting here. So I think in terms of pharmacologic treatments used before or after, besides the blood products we talked about, when is the optimal timing? Should they be used before or after failure of conventional methods? And here, what I'm referring to specifically, besides the uretonics, which are standard of care, would be things like fibrinogen concentrate or tranexamic acid, which we talked about earlier in terms of prevention, but really we're talking more about treatment here. What is your perspective on this, Professor Sentilhes?
As stated before, in the woman trials, as you know, the survival benefits associated with the earlier administration of TXA acid in these women with active PPH suggests that tranexamic acid should be given as soon as possible to achieve clinical benefits, as stated by the World Organizations, the World Health Organizations. And recently, the emotive trials provides additional indirect evidence in favor of an early use of TXA when PPH occurs. And for the Fibrinogen administrations, as you know, observational studies of women with PPH indicate that a low Fibrinogen concentrations in the early phase of PPH is associated with excessive subsequent bleedings and blood transfusions, suggesting that an early use of Fibrinogen might improve maternal outcome related to blood loss. Unfortunately, randomized controlled trials did not confirm this hypothesis.
So, Professor von Heymann, can you talk a little bit about specifically the fibrinogen concentrates and what your perspective on the use on those would be?
Yes, thank you. And I agree with Loïc. Unfortunately, the studies that we have, and we have at least 3 prospective randomized trials looking at fibrinogen in PPH patients, they did not show significant benefits for the patients treated with fibrinogen. But if you closer look into the data, then you see that in all 3 studies, the patients who received or were randomized to the fibrinogen arm, they did not have a deficiency of fibrinogen. And they still had normal levels because fibrinogen synthesis is upregulated during pregnancy. And so it takes some time and it takes some blood loss to make those patients fibrinogen deficient. And unfortunately, these 3 trials captured patients who had an almost normal fibrinogen, and that is unfortunately somehow a failure of the study design and not a failure of the drug, because that is indicated in patients who are deficient of fibrinogen. And I'm sure that in those patients who are deficient of fibrinogen concentrate is the most effective and quickest way to replenish fibrinogen. And I'm sure, although it has not been shown in prospective randomized trials, that fibrinogen concentrate is superior to other treatment options like plasma or cryoprecipitate. But unfortunately, we do not have these data right now. But what I would like to state, and this goes now back to the tranexamic acid discussion that we had before, if I assume that there is not only loss of fibrinogen, but also some fibrinolytic degradation due to an increased fibrinolytic activity in the blood of the patients, then it is strongly advised to give the tranexamic acid before you give the fibrinogen concentrate. Otherwise, the replenished fibrinogen will be broken down, and then it may be not very useful for the patient.
These are, I think, really interesting points, and that we've all brought up here in this conversation topic. One, I think, interesting offshoot or segue from this is you mentioned the fibrinogen concentrate is much rapidly to administer. And for those listening who might not know, that FFP or cryoparticipate takes time to thaw, and sometimes that can lead to delays. But the fibrinogen concentrate is often in the shelf. You mix with solution and can pretty rapidly administer. So time is important, as I mentioned earlier, with minutes can make a difference and added blood loss. I think speaking to a little bit about, this is a good area, I think, to incorporate the lab testing. I'm curious what you're all, in terms of perspective or utilization of point of care devices or lab tests to guide transfusion has been, and where do you think the gaps in this area are?
Yeah, I think so. We need to have additional evidence about the use of bedside test and viscoelastic test and hemoglobin test bedside to guide the transfusion. Maybe it could be very helpful to try to give the good medication to the good patients. But unfortunately, we don't have a lot of evidence about that. So, because as you know, the people who do not believe in the bedside test to guide the transfusion don't want to perform randomized control trials. And the people who guide their transfusions because they believe that the lab test helps, they do not want to perform also randomized control trials. And so it's quite difficult to have evidence. And as it has been underlined by Christians about the Fibrinogen trials, that one big issue when we try to have evidence about PPH and ongoing PPH and severe PPH, that when we perform eligible women and we include women, sometimes it's not severe PPH. So we don't have include the good women because we don't have time when there is a very severe PPH to include the woman and to give the administrations and to perform the randomizations. So it's one issue because when we have a negative trials, maybe it's not the drugs or the strategy that is negative, as stated Christians, it's only the design.
Professor von Heymann, do you have any additional thoughts here?
Yeah, well, I think there is a large ongoing controversy on how to use blood tests and point of care coagulation testing in patients who are bleeding, because we always have the feeling that time is running away and we cannot wait for the blood results and we have to treat, otherwise the patient deteriorates and bleeds to death. And so one of the advantages of point of care blood testing is that you really can have it at the bedside, very close to the patients, and that you have a time advantage in that you have results, interpretable results, within 5 to 10 minutes after the test has been started. And usually the central lab takes much longer. And this is the advantage that we have with the point of care tests. And I honestly doubt that the specific tests from the point of care coagulation testing are better than that what we have from the central lab. But the time advantage is, especially in bleeding situations, a large advantage for the point of care testing. But as Loïc mentioned, we do not have very good evidence from prospective randomized trials which thresholds we should adopt for guiding our substitution therapy with, let's say, Fibrinogen or PCC or even factor 13 or even recombinant factor 7A. So that means that in the end, the attending anesthesiologist and obstetrician have to make up their minds on when to give what.
Yeah, no, thank you for that, both of your comments and interesting points. I think the takeaway from this question is that it seems that tranexamic acid early use is critical for postpartum hemorrhage, and that saves lives, and that delays may add additional morbidity after the delivery. Fibrinogen concentrates or other pharmacologic interventions, as we alluded to as well, are maybe not always available or don't have the lab testing thresholds clearly identified in evidence-based algorithms that both obstetricians and anesthesiologists and other providers can agree upon. So I think that's a deficiency or gap right now we have in our field that can improve. Let's shift gears to what does the multidisciplinary team really look like in the management of postpartum hemorrhage? I think this is a very fundamental to successful outcomes to have a multidisciplinary approach. As we know, it can be very hectic at times, and the personnel involved range from the obstetrician to anesthesiologists, which we've clearly identified as a key personnel. However, the nurses and the transfusion medicine specialists or even hematologists sometimes might be also involved in patients who are severely coagulopathic or go into the ICU, for example. What thoughts do you, both of you perhaps have on the importance of this and how these team members should interact, or even barriers in communication? Professor Sentilles, if you can comment first.
Yes, it's a very important question because, as you know, most studies focusing on PPH aim to test the effectiveness of a drug, a device, a policy of blood product transfusion, but few studies have assessed the impact of the organization of care, in particular the role of medical staffing on PPH-related outcomes. So, however, it has been shown that a delayed call for obstetric assistance is associated with a 2 times higher risk of severe PPH compared with cases where the senior obstetrician was present or called within the minutes, and it's the same for a delayed call for an anesthesiologist. So we know that it's important to call everybody, anesthesiologists and obstetricians, since the diagnosis of PPH. And it is obvious that the good communications between obstetricians, anesthesiologists, and midwives, nurses is a key factor for an optimal management of PPH. And I think that the PPH management has to be together and not each on its own.
Yes, I couldn't agree more. Professor von Heymann, what are some thoughts you have on this topic?
Yeah, well, I completely agree with Loïc, and to my feeling, the greatest challenge is to state and to make the diagnosis of this patient has a PPH, and I have to take action. And if I've done this diagnosis, then I have to call an anesthesiologist. Then I have to call more personnel, and I have to call midwives, and I have to call anesthesia nurses, and so on. And then I have to call a senior obstetrician to get his opinion. And if this diagnosis is made and everybody knows what he has to do, then it makes a team approach much easier because everybody knows what PPH means, and then we can, on both sides, agree upon what will be the next steps that each of us has to take. shall we take the patient to the operation room? Can we leave it in the labor chamber or whatever, just as an example? And so establishing the diagnosis to me is key. And then the rest of the management should follow a treatment algorithm that should be somehow derived from guidelines based on existing evidence, and that treatment algorithms should be adapted to the conditions of the hospital the patient is delivering in.
Yes, no, I agree too, in the sense that every health system is different in terms of their access to the products or specialists, and especially in low resource countries. I think it's important to have a plan of that's feasible in those settings of what should be approached. And I think both of you made the similar points about early recognition and early calling of the specialists. I agree, and as well, I might add that the continual communication, sort of not that initial trigger, but perhaps ongoing discussion, because things can change very quickly with the patient's status, and I think the continued communication for that, few hours, 1 to 4 hours or whatever, if it's in a severe postpartum hemorrhage, would be important. So, to conclude this podcast, we'd like to provide a few clinical takeaways based on our discussion. If I could ask Professor Sentilles, would you mind providing 2 key clinical takeaways?
So as we have discussed, I think that the most important thing is that is the communications, and an excellent communication is required for the management of PPH. And I think that simulation trainings may help to improve the communications among the different teams. And the second point is there is no room for improvisation in the management of postpartum hemorrhage, and all team members must know by heart their role and the management PPH algorithm that has been chosen and implemented in their centers.
Thank you. Professor von Heymann, what are your clinical takeaways for our listeners?
As I said before, to me is key that the detection and the establishment of the diagnosis of severe PPH is key to inform everybody in the team that we are dealing with a severe bleeding situation. And then the second point would be follow coordinated between all the departments that are involved, a coordinated treatment algorithm to substitute the patient with what is needed, and so that surgical and hemostatic medical measures are going hand in hand. And that will probably, although has not been shown yet, that will probably improve the outcome of our patients.
Well, thank you so much, both Professor von Heymann and Professor Sentilles. It's been an honor and a privilege to be here moderating the discussion. As well, I'd like to thank the listeners for joining, and hopefully they can use some of the information or the gaps that we've highlighted to inspire some of their future work.
Thank you very much.
Thank you very much.
Thank you.
Thank you so much for this interesting discussion. We've learned a lot from your conversation on the various treatment strategies available for PPH and their corresponding scientific evidence. If you also like this episode and you want to find out more about PPH, then please look for the other episodes in this series on the Obstetrics and Gynecology Medical Conversation podcast under the account of Core2Ed Medical Education. Also, don't forget to rate this episode, subscribe to our channel, or inform your colleagues about it. Thank you for listening, and see you next time. This podcast is an initiative of Core2Ed and developed by Obstetrics and Gynecology Connect, a group of international experts working in the field of gynecology. The views expressed are the personal opinions of the experts, and they do not necessarily represent the views of the experts' organizations or the rest of the Obstetrics and Gynecology Connect group. For expert disclosures on any conflict of interest, please visit the Core2Ed website.